This is a very, very rare case in which we also obtained the patient's informed consent, and I have no financial ties or conflicts of interest to disclose. This is 1 in 58 cases reported in literature. So it's really a privilege to be one of 58 cases reported in literature. Again, a picture is worth a million words. Look at the picture and you can just see the whole story. This is our 77-year-old female who was breathless at just resting, with complete paralysis of her right vocal cord. Look at this huge, nasty-looking goiter extending into the mediastinum, obstructing the trachea, and notice that it is indenting the manubrium anteriorly, extending to the posterior mediastinum, and also abutting the spine. A horrible case. Well, this patient was initially managed elsewhere, and this is what was reported. Her ultrasound revealed the presence of suspicious central and lateral lymph nodes. Fine needle aspiration reported poorly differentiated thyroid cancer. But take a look at the sentence which I copied exactly from her file. Most likely represents anaplastic carcinoma. And if you look at her chest CT, we can see bilateral subcentimetric lung nodules, which probably represent metastatic disease. Now, what was she offered at that center? Her management plan was a surgical airway tracheostomy, external beam radiotherapy, and a life expectancy of 3 months. This is what the parents were told. Well, I did not agree with some details. First of all, we all know anaplastic carcinoma. Anaplastic carcinomas are always considered stage 4 cancers. They are divided into 3 subgroups, A, B, and C. A is confined to the thyroid gland, B extends regionally, and C means distant metastasis. So, some of us have misconceptions, or there is a dogma or misconception in the surgical and medical field that when you're dealing with an anaplastic carcinoma, then you're only offering patients palliation. It's an inoperable cancer. An operation can make the tumor more aggressive and even result in demise earlier. But it's not true. Nihilism, no more. This was the title of the most recent American Thyroid Association guidelines, which were still there in 2009, which always remember that for stage 4A and 4B, aggressive surgery is always a favorable prognosticator in anaplastic carcinoma. I operated upon my aunt, the sister of my father, in 2017, a case of anaplastic carcinoma, stage 4A, and till date, she is alive and well. So it's been 4 years, and I have others in my series which are doing perfectly well. So, what I didn't agree with was the simple piece of information in which the cytopathologist concluded that this most likely represent an anaplastic carcinoma. You cannot condemn a patient to stage 4C, which is inoperable in any guideline, okay, by saying that this most likely represents an anaplastic carcinoma. And using this word, you only destine her to external beam radiotherapy and a life expectancy of most probably 3 months or less. So what we opt to do is to perform a true cut biopsy again. And the true cut biopsy came out as papillary thyroid carcinoma, with all the nuclear features of papillary thyroid carcinoma. Nuclear overcrowding, nuclear clearing, and nuclear grooves, and etc. And therefore, when you're dealing with a differentiated thyroid cancer, even though it is metastatic, you have to always be aggressive, because metastatic disease will respond to radioactive iodine ablation therapy. So we opt to go for surgery in this patient. Again, do we need a cervical approach or an extracervical approach? We're dealing with a cancer. It is very harsh, very aggressive locally. She has central and upper mediastinal lymphadenopathy and lateral lymphadenopathy. We always follow the golden rule. Always attempt a cervical axis, and then لكل حادث حديث. حقيقة, union of forces is always necessary. And we united with a very, very courageous anesthesiology. Allah yarhamu, Dr. Firas Abu Aisha. He was brilliant and he was a close friend, and we opt to go for surgery. We performed a total thyroidectomy with bilateral central compartment neck dissection, by which we refer to level 6 and upper mediastinal level 7 lymph nodes, and a left lateral compartment neck dissection extending from the base of the skull to the clavicle. Again, you can see that this is the right side. The tumor has been shaved completely off the trachea. This is the trachea. The nerve here is inapparent because we did not try to even preserve it. It was completely invaded and paralyzed preoperatively. This is the esophagus, where you can see the tumor being off the esophagus and all the way into a groove into the mediastinum. You can see the left side here, the recurrent laryngeal nerve is apparent and well preserved. And you can see the lateral neck here. I will orient you. This is the common carotid artery. I don't know if the pointer reveals. This is the internal jugular vein. This is the vagus. And this is the plexus, and this is the spinal accessory nerve. And here, sitting on this, were all metastatic lymph nodes. And here is the surgical specimen. Look at this ferocious tumor. These are the level 2 to 3 and level 4 and 5 lymph nodes. So this was sent to, before sending it to histopathology, I would like to look at the cervical axis. So this was all performed through a cervical axis, and the histopathology was reported by Dr. Faiz Al-Hajiri, who is here today, and he can give us some insight if he would like. A 9 centimeter mixed papillary and squamous carcinoma. The total number of lymph nodes harvested were 28, out of which 17 were positive. So we did more than required in clearing her lymph nodes. The largest lymph node was 2 centimeters, and again demonstrating a very aggressive feature, which is the presence of extranodal extension. Mixed squamous papillary carcinoma. I think when he even reported that, he was puzzled, when he told me that. I know 15 variants of papillary thyroid carcinoma very well. I've never heard of that in my life. Squamous cell carcinoma in the thyroid. So, after digging into the literature, we found that there are 58 cases reported in literature of a mixed squamous and papillary carcinoma, and most accepted theory or hypothesis is that squamous differentiation is an aggressive pathologic finding and is a first step towards dedifferentiation. So this cancer was not an anaplastic cancer, though it was moving towards an anaplastic carcinoma. Other hypotheses in the literature that are not very well supported are tumor-to-tumor metastasis, squamous cell carcinoma metastasizing to papillary carcinoma. Some cases have been reported in literature, or tumor collision, having two histologically and morphologically discrete tumors coexisting in the same patient. So, a case that we do know little about, has no management guidelines. Everyone in the literature does whatever they want. So we opt to first, we have a differentiated component and we have a squamous cell component that does not respond to radioactive iodine. However, the squamous cell component may be affected by the bystander effect of destroying the differentiated component. So we opt to give her a high dose of 200 millicurie given by Dr. Ode of radioactive iodine. Now, follow-up at 6 months. Neck ultrasound was free of any thyroid, central or lateral disease. So we had a free neck and a free upper mediastinum. However, we had biochemical evidence of disease. The thyroglobulin dropped from 164 to 26. However, any reading above 2 for us means the presence of biochemical disease. So a whole body scan on follow-up was negative. So in the presence of biochemical evidence of disease and the absence of structural disease, you're dealing with a case of radiorefractory papillary thyroid carcinoma, and this is an indication for a PET-CT. Now, PET-CT was done, and it really demonstrated the presence of bilateral lung nodularity. However, and a year after, we followed by another PET-CT, the lung nodules increased in size and in activity. But that's all okay, because a year after we celebrated her anniversary, she was so happy, so functional, so active, with a good quality of life, and she was living as if she had no disease. And this is the bottom point. Whenever we say that aggressive surgery at the right time is a positive prognosticator, prognosis means either disease-free survival or overall survival plus a good quality of life. We did not want to take her into the dilemma of external beam radiotherapy and try chemotherapy, which was reported to have bad results in other cases. We did not want to go through the hassle of TKIs or other therapies, but she has a good life, and now we will soon celebrate. We have made it a tradition to celebrate each year her anniversary. So in this September, I'm invited there to Madaba, where she lives, to celebrate her again. And she is doing very well. But what was interesting, this is her son, this is her daughter, and I operated both. Yes. I think it's important to explore a genetic component or a familial component in this specific case. But unfortunately, whenever you want to investigate, you need financial resources, and patients would not pay. And if you want to pay for every patient, معناته تقعد على الرصيف أحسن لك. This is very unfortunate. But papillary carcinoma. So this further proves that it's a de-differentiation process, probably. This guy I operated, she was operated, they were both operated on the same time, on the same day. Her cancer was confined to the thyroid. For this guy, I performed a central neck dissection, and she had positive central lymph. التنتين عندك ما حكيت لك صح. So what did we offer our patient? We offered her prolonged survival with a better quality of life. And this means that she was offered much instead of dying sitting at her home and her children watching her dying, she could probably, I think, she's more likely to die from a car crash rather than from her metastatic lesions in the lung. A lot of cases we encounter and people tell them that they're inoperable, such as this lady whose presentation was a fungating lymphadenopathy in the neck. And again, we operated her, performed a whole neck dissection, thyroid, central and mediastinal lymph nodes with unblock removal of this matted mass of lymph nodes. So, another success. This is another patient who we operated. This is the post-operative result, and this was the presentation. Retrosternal goiter with superior mediastinal, superior vena cava syndrome, and look at this huge fungating parotid tumor. We operated both tumors simultaneously. This is the thyroid, this is the central trachea, this is the parotid lesion for which we did a rotational local flap, and the patient is doing absolutely well. It's very important to extend my thanks to my great team and colleagues, Sister Iman and Dr. Muhammad, and to all the dedicated staff in hospitals, doctors, nurses, anesthesiologists and anesthesia technicians, and the great people I collaborate with, from endocrinologists, nuclear medicine consultants, who really make life easier, and the great comfort when we have Maysa, Mansour, and cardiologists, and we are very, very happy to be part of such a great team. And it's so great when you have someone like Dr. Faiz reading all these specimens and giving such beautiful reports which are scientific and flawless, alhamdulillah.